Alrighty, let's go through the first case. This is a 52-year-old male who complains of nausea and syncope while on a treadmill. So that's the complaint. The history: he was on the treadmill. He became nauseous and diaphoretic. He felt like he was going to pass out. He stopped the machine, lay down before passing out. So he had near syncope. He gets nauseous and lightheaded when he sits up. No past medical history. Exercises regularly, which that's important to know, just from his exercise standpoint. No smoker, no alcohol, no drugs. So pretty healthy, relatively young guy, no medical problems, who gets nauseous and diaphoretic on the treadmill. So that's the history. So on exam, move this up a little bit, he's pale, he's diaphoretic, and not that I've just worked out sweat because you just started on the treadmill, but that, I'm sick sweat. Weak radial pulse. Let's see, lungs clear, abdomen is soft. Let's see, he's alert and oriented. Vitals. Here's where we get it. So BP was 80/40. Pulse was 50. Respirations are 18. Sat 100% on room air. So what other assessments are indicated? So what types of things do we need to do? This is a pretty sick patient. He had these symptoms while exerting himself. There's no mention of any chest pain here. However, it's kind of concerning that he's nauseous and diaphoretic, and with any kind of exertion, he gets nausea and diaphoretic. So definitely, in addition to these, what are the other, the other assessment that is indicated is a 12-lead EKG. That's definitely something that's indicated. There are other assessments that you'd consider would be indicated. Think about that. Write that on your worksheet. So we'll get that in a minute. But what is the differential for this case? What is the differential for this case? Well, just given the patient's age and some of the symptoms, acute coronary syndrome or MI fit into the differential. He's not really having any chest pain or shortness of breath, so I really don't think that things like PE would come into play. Probably not CHF, because hey, he's not having trouble breathing, and plus he's a pretty healthy guy. He exercises regularly. He's probably got a decent cardiac output. What else? Something that's a GI source. Is there gastritis that for some reason came on relatively suddenly while he's on the treadmill? That one's a little iffy. Same thing with biliary colic, gallbladder disease. That can sometimes cause some problems up into the chest. That can cause some nausea and vomiting. And it may or may not include a significant amount of pain in the right upper quadrant. So that it could be a possibility. Is there something else bowel going on? Is there colitis? Is there gastroenteritis? Just he hasn't thrown up yet. He hasn't had the diarrhea yet, so I guess that's probably not gastroenteritis. But those are some of the things that may be going on. So let's take a quick look at the image for this case here, and I'm going to bring this into a size of the recording. Now ignore the top for a second here, because we really should be able to do this without reading the machine interpretation, at least initially, and then we use the machine interpretation to support what we have. But in this, it's actually a male patient. Sorry, my example is EKG is a female, but this patient is a male. But what we have here is we have a bradycardic rate of about 43 beats per minute. That fits fairly close to the 50, so that's somewhat reasonable there. But what really is striking is if we look at these inferior leads here, we've got some pretty marked ST elevations in leads 3 in AVF, and then some elevation in lead 2. And again, we go from the baseline, which I'm a little off there on the baseline, but if you draw attention to that, you definitely see there's some ST elevation. And then we've got these reciprocal changes in the anterior and lateral leads, including here let me change color to show the reciprocal changes here, just so that they fit nicely and identify as and get confusing. So there's definitely an issue here. This gentleman is having an inferior wall MI. So this actually does fit in with the signs and symptoms, right? That's the image. Oh, sorry, let's go back to the case. So if we kind of scroll back, what are the signs and symptoms? He was exerting himself. He became nauseous, diaphoretic, near syncope. He is bradycardic. He's hypotensive. Respiratory-wise, we're looking pretty good. He's pale. He's diaphoretic. Weak radial pulse, but his abdomen is soft. He's alert. He's at least perfusing his brain enough. So this is kind of pointing probably towards a non-abdominal source, probably more cardiac source, and that 12 lead cinches the diagnosis there. We're going to switch back to a black pen. So that's the differential. What are the treatment priorities? Aspirin, 324 or 325. The 324s are the chewables, which works out well. So we get aspirin on board. No nitrates, right? Because he's hypotensive. 2, he's got an inferior wall MI. So the nitrates are gonna drop the preload, which ends up causing more hypotension and more perfusion. We can treat the nausea with whatever agent you have. Some places have, and sorry for using trade names, some places have Zofran, some places have Reglan, some places have Compazine. Whatever your antiemetic du jour for comfort. And then I think this guy is hypotensive. We definitely need IV fluids here to increase our preload. Now once we get some fluids in, and again there may be some anterior wall ischemia. However, there's not an anterior wall MI. Once we get the fluids going, if they're not fluid responsive, then we may need dopamine to help kick in the beta agonist. There's some thought that even if we do low dose norepinephrine, let's spell that correctly. Low dose norepinephrine, that will actually increase coronary perfusion. Without significantly affecting the afterload. So the norepinephrine kind of fell out of favor about 10-15 years ago, kind of coming back into favor. Obviously, sepsis, we'll talk about that separate, but even with cardiogenic shock, a little bit of low dose norepinephrine may be reasonable. But so that's that. So those are our treatment. We need to reevaluate the patient. What kinds of things should we reevaluate? Definitely vitals, definitely symptoms. Serial 12 lead EKGs. The paper is cheap. If we need to get more than one, get more than one. That can sometimes help show improvement in perfusion. That can sometimes show some worrisome things. Even in the case of someone who is not having a STEMI, serial 12 lead EKG sometimes can uncover very serious cardiovascular disease. So that's very reasonable to do. And then finally, disposition. Where do we need to bring this patient? He needs to go to a STEMI center forthwith. His symptoms just started. He's a very functional guy, so we need to be pretty aggressive at getting him to a STEMI center. Again, this depends on your local resources. There are still some areas of the country where a patient in this situation would end up getting into the emergency department, get fibrinolyzed, and then sent to a STEMI center. There's other places where within the regional cardiac care system, paramedical services may be called to transport this person to a distant STEMI center, and certainly in a lot of areas of the country, this patient would bypass your local emergency department in favor of getting to a STEMI center, just to decrease the total amount of time that this gentleman is in the pre-hospital phase. So that's case A.